So we're going to go ahead and get started. First and foremost, thank everyone for coming out this evening. I know this is a tough week. It's holiday season and folks are traveling, so we greatly appreciate you coming out. Myself and Dr. Adam Ramsey are extremely excited about tonight because this is the launch of our new education series, and we have a star with us tonight, Dr. Ansel Johnson. And for those that are unfamiliar with him, he is the clinical director of Vision Salon Eye Care Associates, and he is experienced clinical director and optometrist that has demonstrated a history of working in the medical practice industry. He's skilled in eyewear, glaucoma, diabetic eye care, macular degenerations, technologies in eye care, and practice management. He has a strong healthcare service professional, and he's focused in optometry, and he went to school at the New England College of Optometry. So I'm going to hand it over to Dr. Ansel Johnson to take over, and he's going to educate us about diabetes this evening. Thank you, Dr. Johnson.
Thank you very much, Daryl. Man, I really appreciate you guys. Humbly, just by God's graces, thank you for having me on.
Yeah.
Just to share some knowledge and just the whole Black eye care perspective, media and social media is just, it's going to take us African-American eye care providers to the next level. And I appreciate your vision, and hey, let's just ride that together. And I know it takes a lot of work, but hey, let's get started. And as he said, I am the clinical director of Vision Salon Eye Care Associates. I'm also a diabetes care and education specialist, and I'm certified pre-diabetes lifestyle coach. So a lot of work kind of has come into my focus here as a diabetes-friendly eye care facility. I'm also the medical director of United Eye Care Providers, which is the largest independent network of private practice providers in Illinois. I'm the only African-American member of over 100 optometrists. Also own, as a Vision Salon Eye Care Associate subsidiary, our Knockout Diabetes AADE certified, nationally certified self-management education and support program. And that's key because not only the only one in the state of Illinois, there's only 2 in the country. Dr. Paula Newsom was the very first, and I was helpful with her setting that program up in Charlotte, North Carolina. And then a couple of months afterwards, we get ours certified here in the state of Illinois. I've been a member of the American Association of Diabetes Educators for over 20 years. So that has kind of helped fuel my passion, and I'll talk a little bit more about how I've utilized that membership. Is obviously has been very helpful in setting up our program here, but in terms of helping our patients. Again, a certified lifestyle coach. I'm also the co-director of the Illinois State Director for the National Optometric Association. So this presentation is really just a teaser because I am presenting at the National Convention in July in Hollywood, Florida. So that's Dr. Ramsey's neck of the woods. And so this is just a teaser, and you'll get more meat to the bones if you all sign up, come to the convention in Florida. So, and on to that, I've been in private practice for 29 years. So it's been 29 and a half years we've been here in Blue Island, Illinois. So let's talk a little bit about diabetes and how to build the optometric primary care practice by helping patients who are at risk or living with diabetes. And a few learning objectives to today. I want to outline and help people understand their role and opportunities as an eye care provider for those and to those patients that are living with or at risk for diabetes. Identifying that patient's risk, and there are some clinical guidelines. The AOA just came out with their 2nd edition of their clinical guidelines for managing patients with diabetes. And again, in another presentation in our convention, we're going to tear that apart and apply it to all of our practices. And I want to help familiarize the listeners with some low-tech and some high-tech applications, some cutting-edge applications that I use every day in managing our patients with diabetes. And then finally, we're going to talk about marketing and practice strategies to support those living with diabetes and growing a really diabetes-friendly practice. Now, the National Institutes of Health recognizes how important optometrists are in managing patients with diabetes and on a national scale. So they have an initiative called PPOD, which stands for Pharmacy, Podiatry, Optometry, and Dentistry. And so if the National Institutes of Health thinks that much about optometrists, we need to take advantage because we are in the forefront. When I first started school, it was hit into me in optometry school, we're a primary healthcare profession. So I don't care if you're a retail, private practice, a medical practice ophthalmologist, corporate, we are a primary healthcare profession. And with the PPOwer program, they have a Healthy People 2020 objective, which is already here. Prior to 2008, they're estimated that less than 50% of people or adults that are living with diabetes had had a dilated eye exam. And their target for next year is to push that up to 58.7%. It's been increasing. In 2008, it was 53.4. So they're pushing it closer to 60%. So that's still nowhere near the number of people that should have a dilated eye exam. And my philosophy is to really take that to the next level. A dilated eye exam for a person diagnosed or living with diabetes is really totally inadequate. And again, I'm going to brush over the facts. We all know diabetes is an epidemic. That cow has left the barn a long time ago. But 1 in 4, or 30.3 million Americans have diabetes, and 1 in 4 do not know it. 2 out of every 5 persons living with diabetes are expected to develop diabetic retinopathy, or excuse me, 2 out of 5 Americans are expected to develop type 2 diabetes in their lifetime. So it's 40% of the population is expected to develop diabetes in their lifetime. And guess what? Eye care is really closely tied into that. 4.2 million adults. It's 1 in 4 adults with diabetes age 40 older have diabetic retinopathy. 1 in 4 adults over 40 diagnosed with diabetes have diabetic retinopathy. Diabetes is a huge, huge drain on our national healthcare budget. Almost $250 billion are dedicated to diabetes, lost work, wages, total medical costs. And I always point out to our participants in our diabetes class, you all see all these the kidney dialysis centers popping up in the Black neighborhoods and Hispanic neighborhoods. And that's because of the huge number of people that are living and walking around with diabetes that have terrible kidney problems. And so 1 in 3 adults with diabetes and 1 in 5 with hypertension have chronic kidney disease. So hence the kidney dialysis centers. I went to a cardiometabolic conference a little less than a month ago because I really wanted to see how diabetes fit in and how other people looked at it. And obviously I was the only optometrist out of thousands of people, but one of the things I realized, again, talking with cardiologists, people, kidney specialists, nephrologists, and they talk about cardiovascular death, risk, readmissions, and vasculature. And I'm like, you know what? We are the only profession that really looks at blood vessels all day long. And we have, sooner than almost anyone else, have a really good sense of how their overall health is. So keep that in mind every day as we see our patients. Don't take ophthalmoscopy for granted. If you don't see hemorrhages, I want to instill in everyone this evening a change in mindset. When we see someone that's at risk for diabetes, been told they're pre-diabetic, borderline, or living with diabetes. Now, diabetes, the epidemic has kind of paralleled our national obesity epidemic. And if you see in 1994, where most of the countries, less than 14% of that were obese, to 2015, which is the latest data from the CDC, we're over 26%. So we're a country that's 1 in 4 people in our country right now are obese. And take that along and measure that along with almost 10% of individuals in our country are living with diabetes. Again, low-hanging fruit. We see these people, I don't care what mode of practice you're in, unless you're in a pediatric practice, we see these people every day. And again, we see a lot of these people. Why? Because of blurred vision. We take a thorough history, visual acuities, eye movements, all that stuff. But a lot of times, time and time again, they come into our office, blurred vision, they come back, throw the glasses back at you, and say, Doc, I can't see out of these. We do an A1C or a finger prick glucose, a random glucose, and their blood sugar might be 300. This is not a lecture on or presentation on diabetic retinopathy. We're all doctors that are very smart, and but I do need to point that out. There are different stages. And here where you see early diabetic retinopathy, my whole focus is developing protocols and getting everyone to be on board with detecting diabetic retinopathy before there are any obvious hemorrhages. And we can do that. Some less common, less obvious ocular manifestations. Diabetes is a cardiovascular, has a strong cardiovascular component. And as we know, the optic nerve is richly innervated with blood vessels. And so when that is compromised, you can get ischemic optic neuropathy, because not only do you have diabetic retinopathy, diabetes, there is a diabetic neuropathy. Also, disorders of eye movement, again, secondary to diabetic neuropathy, where you can have a patient that's seeing diplopia, or if they're not diplopic, they get a lot of fatigue and strain, or they just can't concentrate or focus because of eye strain. So consider eye movement problems. And there's some nice technology that can measure eye movements that you can incorporate in your practice too. But ocular movement disorders are a key thing that can often be overlooked. Dry eye. Diabetes is a very inflammatory condition where we have inflammation throughout the body. And as we know, inflammation of the eyelids can lead to what? Dry eye. So big trend right now in eye care, optometric care, is treating dry eye. Well, you have to look at the underlying symptoms and what's the underlying causes. So we really need to deal with that patient in an anti-inflammatory sense, looking at the patient holistically. And there's ways to do that with lifestyle changes, diet changes, and also supplements that really can help reduce inflammation besides the palliative methods that we often use so many times. And again, some other less common things that we see: impairment of color vision. Diabetic retinopathy, diabetic neuropathy, ocular neuropathy can affect color vision in the macula. And we see that, and we'll talk later about that, double vision. Also, eye aches and eye pain. Again, we talked about the ocular motor dysfunctions can cause asthenopia, eye pain, things of that nature. Inflammation in and around the eyes. Glare and contrast sensitivity issues. Well, guess what? Diabetics tend to develop cataracts at a little younger age and more rapidly. I just had a patient today, just wanted a pair of new glasses. I said, dude, you're borderline diabetic, and probably the diabetes, the fluctuation in blood sugars has caused you to develop cataracts in your early 40s. And unfortunately, we have to try to relate and communicate with our people that sometimes you're just in denial, and you have to meet people where they are. But I had to show the guy there's not much improvement. I mean, we've all gone through that with our patients that are living with diabetes. And reduced night vision. Again, reduced contrast sensitivity, cataracts can cause a reduced or problems with night vision. Standards of care. I mentioned early on that the AOA has produced a really nice publication on standards of diabetic eye care. But not only AOA, the ACE, which is the Association of Endocrinologists, has a standard of care. The ADA, American Diabetes Association, has a standard of care. AADE has a standard of care. So there's a number of different standards of care in terms of managing patients that are living with diabetes. And all of them are really not the same. All of them are not the same in terms of eye care. So we have to go out and read those publications and kind of sift and see what applies to our practice. For right now, adults and children age 10 or older with type 1 diabetes all should have an initial dilated eye exam by an optometrist or ophthalmologist within 5 years of onset of diabetes. Now, the thing of type 1 diabetes, usually that occurs so acutely, the retinopathy doesn't really develop real quickly in type 1 diabetes. They get so sick more rapidly than diabetic retinopathy was set in. So the urgency is not quite there. Whereas in type 2 diabetes, which is 90% of patients that are living with diabetes are type 2, the exam should be really shortly after diagnosis. Why? Because most people with type 2 diabetes, it's been diagnosed late. So basically 5 to 7 years later, I think most of the statistics are showing. Those diagnosed with diabetes during pregnancy should also have a dilated eye exam within 2 weeks of diagnosis. The reason being, a young lady that is expecting or pregnant, their hormones are just raging. And also insulin resistance goes through the ceiling during pregnancy. So you can develop retinopathy. And again, if they've had diabetes prior to their becoming pregnant, it can progress pretty rapidly and actually jeopardize the unborn child because they have to get their blood sugars under control. Continuing standards of care. Baseline exams, of course, are necessary. OCT and retinal photography exams should be considered in as well as fundus exams. So in their fundus exams. OCT is pretty much more widespread now, but the nice thing about OCT that's coming more and more cutting edge is OCT angiography, and we'll talk about that a little bit. But OCT evaluation, retinal photography evaluations, I think are extremely crucial, and they are not in the standard of care in terms of being mandatory, but extremely strongly recommended. The other thing that we need to do that can help all of our practice and encourage participation of patients into diabetes self-management and support programs. You need to locate those programs in and around your area if they are. They're mainly located around hospitals and large clinics. Some HMO settings will generally have these kind of programs. You'll be surprised that they can be a really good source of referrals because they have patients that are referred by their primary care providers, and they may not have their own eye doctor that can follow them over time and follow progress over time in terms of their retinal condition and overall. So sometimes you might have to learn how to talk diabetes educator because in terms of the success that diabetes education will do in managing someone, in terms of lowering average A1Cs, it's been shown many, many times, evidence-based. It can also be an increased indirect source of revenue by partnering with local diabetes education programs, as well as your physicians and endocrinologists and things of that nature. You're helping referring providers adhere to HEDIS goals. One of the things that really prompted me to do this, you talk to patients, have you seen a diabetes educator? Most of my patients, I'd say 80% said never talked to a diabetes educator, or they've been living with diabetes for 5, 10 years. They may have talked to a nutritionist at initial diagnosis, and that's it. So the knowledge that is out there for people living with diabetes changes so rapidly. It's changing every year. There are new medications, there are new technologies that really are very helpful and cutting edge in terms of helping people living with diabetes. And we as optometrists, because we see these people all the time, we need to be aware. You don't have to have your own certified diabetes education program, but we need to know the types of medications and the technologies that our patients are using. I'll give you another example. Had a teenager that was type 1 diabetic come to my office. And hopefully people have started hearing about these continuous glucose monitors. So instead of pricking your finger, people wear these glucose monitors on them and they can check their glucose anytime they want, an iPhone or a reader. And this young man said, this thing alarmed when my glucose, when my sugar went low when I was asleep. Literally saved my life a couple of times. So people that take insulin are at higher risk for developing low blood glucose sugars, which can be life-threatening. So can you imagine if you're driving, blood sugar drops in an accident, or again, at night, you're in bed, blood sugar drops, and you may not wake up. So it can be a very dangerous situation and needs to be monitored. And we need to know um, if our patients, if that's the case, so we can share that information with um, their primary care physician or the endocrinologist, because they may not be aware. One other little pearl is that a lot of times endocrinologists, it takes 4 to 6 months sometimes to even see an endo. They are very, very busy. So we're another touch point for these patients to see how they're doing. And again, it's changing the mindset and it's helping lock those patients into our practice. Another thing that we can do in terms of standards of care is educational literature and listing of support services or other resources. It should be made available, and that's from the AOA guidelines. So in other words, we should be resources for providing our patients literature and support services. I'll get into some of the things that we have in a minute. One other thing I want to talk about is diabetes. What are the criterion? Those people that are normal have A1C that's 5.7 or below, pre-diabetes between 5.7 and 6.4. Diabetes A1C is 6.5 or higher. Very important. So if we just looking at the A1C test, and I think this slide, if everybody can take a shot of it and hold it, and so you're aware of that. And what's the value of wellness eye care? And I like to term, and I tell my patients, I'm concerned about your wellness. We're not trying to do eye care on the emergency end. We want to make sure we maintain your eye and vision wellness. And that's why early detection and treatment can delay or prevent blindness in 90% of people living with diabetes. And again, 1 in 5 newly diagnosed type 2 diabetic, they have retinopathy at diagnosis. How do we control that? Good glycemic control. And again, we're another touch point to put people on edge with that. And we need to manage patients in a way to help avoid macular edema. I tell people, I don't want you to get injections. My job is to keep you from doing that. And what's the opportunity? Well, there's one licensed eye care professional for every 3,500 people with vision correction in this country. And that's from Review of Optometric Business. 40,000 ODs, probably more than that now, 18,000 OMDs. 57% private practice, and we know that's going to shrink a little bit more. But again, managing people with diabetes is an opportunity for everyone that sees patients. So just some numbers, if you want to crunch some numbers, estimate 10% of your 3,500 patient base that are living with diabetes. That's 350 patients that you're seeing yearly. An estimated private practice that can see 50% of those people under their medical insurance. And obviously, if you see Medicare patients, it's 100% of those. And so for 175 patients a year, you can boost your net practice income quite successfully. So let's look at digital retinal photography in diabetics. So one key, again, this is not a diabetic retinopathy lecture, but if you have a digital camera, always use the red-free filter, because you can detect hemorrhages and that you may not see nearly as easily in a direct photo. Look at red-free. Visual fields. Diabetics, if they have macular issues, diabetic neuropathy, or diabetic macular edema, you can develop a scotoma. So central threshold fields are 10-2. The newer technology, again, I talked earlier, mentioned OCT angiography, computerized extended color vision testing, and full field or multifocal electronic retinal ERGs. Sorry about that. Now, OCT and angiography, again, OCTs are more and more the standard in terms of detecting macular degeneration. It's not OCT, but this is what I get excited about. OCT angiography, which we just brought into our practice this year, where we are able to detect capillary vessel dropout without seeing any dot or blot hemorrhages. So again, before dot and blot hemorrhages, you'll see capillary vessel dropout. And again, it's an opportunity to manage those patients. So we're managing eye wellness. Extended color vision testing, well, approximately 50% of patients treated in an early diabetic retina study showed that they had color scores less than 90% of normal, 95% of normals. And we most commonly see a tritan or a blue color defect. Why? Because there are fewer blue cones in the macula than any other type cone. And so those are the most sensitive to change and damage from capillary vessel dropout or again, diabetic neuropathy. And there are a few computerized extended color vision tests that are easy to administer. These are a couple of products that are out now, commercial products. And all right, and full field ERGs, electroretinography. Again, commercially available, relatively inexpensive considering the reimbursement. But again, this is a measure of global retinal functioning. And this has been backed up by studies that are on the bottom of the slide here. And then again, it's complementary to OCT and extended color vision testing and threshold fields. So let's get to the bottom line. How can we, what type of testing, what's our protocols, and everybody, that's gonna depend on what kind of technology that you have. But these are Medicare allowances, and we're looking at a lot of what I do. If you have a new patient coming in, you have a comprehensive exam, Medicare allowance is $160. And let me back up a little bit. One of the things you should do if you want to get into this, you have to get the patient's medical and vision plans. It's so very, very important. But comprehensive comprehensive exam, which requires the patient to be dilated anyway. Threshold visual fields, full field ERG, retinal photos, extended ophthalmoscopy. Now, I will admit, full disclosure, it's rare that I do extended ophthalmoscopy. That means drawing the retinal eye, because it was like, I don't have time for that. But then I looked at the reimbursement of about $29 per eye for the initial, or $26, $27 for subsequent extended ophthalmoscopy. So a lot of times your digital retinal photos or your OCT does not get wide enough out in the periphery to document things that you see in the periphery. And how do you do that? Extended ophthalmoscopy. So looking at a new patient initial workup, someone comes in the office and says, well, my physician told me to get my eyes checked because I have just got diagnosed with diabetes, or I'm changing eye doctors and I need to see somebody that can handle my diabetes. For a comprehensive exam and all these other tests, you're talking $483. And again, this is Medicare allowance. There's a number of other things that I can do, but I try not to kill the patient on the first visit. So I will have them come back. I'll say, I got to break this up in a couple of visits, basically because, just for your creature comforts and to recover. It's a lot to put a patient through. Some doctors may feel differently about that. But for the second visit, I'll reschedule that depending on their schedule and my schedule to finish. And we'll either do an intermediate exam, a level 3 medical visit, or level 4. That depends on your dilatation. And at that visit, I'll do an OCT. Again, OCT can be interchangeable between the retina photo or OCT. You can dilate them again on a second visit if you feel comfortable. But again, that's your preference. Extended color vision and gonioscopy. Usually I'll do gonioscopy if there's any signs of retinopathy. Why? Because you want to make sure the angles are clear of any neovascularization. So an established patient that time, and I'm just using the established patient with the 92012 follow-up, and the other test, the extended color vision and OCT. I'm sorry, the OCT and color vision is an additional $224. So combining for a new patient with the first and second visit, if you have all the technology, it's over $700. So say you don't have a full field ERG. So you just take $160 off of that. So that brings it down to $550. Say you don't have the digital extended color vision, that's another $60 off. So you're still around $500 for that patient diabetic workup. Non-surgical treatments for diabetic retinopathy, evidence-based nutritional supplements. There are a number of things out there that we use, commercial outfits that we use. And we can talk about that, or you can inbox me and I'll be happy to share what I use. Modifications in diet, modifications in activity, and what we call SMART goals, which are specific, measurable, achievable, and realistic and timely. So I had a patient say, I want to lose 100 pounds. Okay, how are you going to do it? How long is it going to take you? What is that going to mean for you? What does that look like? So you don't let people walk out the door with these vague, I'm fit to do this, I'm fit to do that. So SMART goals are very important. So what can we do to better manage our patients that are living with diabetes? And these are some bullet points for patient education. It's important to note that the annual exams are an opportunity to, again, it's another touch point to reinforce, and I tell my patients, I'm just reinforcing what your physicians are telling you to do. Usually they're overwhelmed, they might be depressed because the doctor will say, you need to lose weight, you need to exercise, you need to watch what you eat, here's a prescription for medication, and I'll see you in 30 days, 60 days, or 3 months. And you go home and you are back at square one. You're just overwhelmed. And I can say that because I am a type 2 diabetic patient myself, and I've lived through that, and I tell my patients I walk those same steps that you walk every day. Another thing, we have to make appropriate referrals to other members of their diabetic team, their podiatrist, their dentist. And so don't be afraid to communicate with those professionals and make those referrals. And then also as an optometrist, we see patients that have extreme diabetic retinopathy that are low vision. So we can provide basic low vision aids, even if you don't do low vision. Just hand magnifiers that are good quality are also often very just helpful for those patients. So again, reinforce making physician appointments, making sure they're seeing their physician on a timely basis, making sure patients know their number, and that they know their blood pressure, that they know their A1C, that they know how much they weigh, and keep up with that. Reinforce the medication compliance. And we monitor our patients' blood pressure, and that's something we all should do anyway. We also weigh patients. That requirement has been taken away from us. We don't have to do that, but we continue to weigh patients and look at their BMI. Encourage diet modification, just little simple things. There's a diabetes-friendly holiday cookbook that we have that we give patients. And providing, again, patients supportive handouts. And also we need to learn, and we learn this in diabetes education, change the language spoken to a patient-centered diabetes. What that means is that you're diabetic, you're diabetic. We don't use that language anymore. We always talk about people living with diabetes because they may have diabetes, but diabetes doesn't have them. And so your verbiage is more supportive. So again, if you don't remember anything, don't call people, oh, you're diabetic. Oh, I see you're living with diabetes. And that's what I've used throughout this presentation. And then again, refer for diabetes self-management education. One of our strengths in terms of managing people with diabetes is that we're available weekends and evenings. Good luck seeing a retinal specialist on weekends and evenings. We also have very strong recall. We can recall patients based on their diagnosis, and we're pretty good at that. And a lot of times we are the first line of eye doctors and generally can identify patients in the earlier stages. So again, we are in the best position to manage eye wellness, and not just whether there's a presence or absence of diabetes education. Now I'm going to try to finish up. We need to verify, again, vision and medical plans, and remind patients of their medical diabetic workup will fall under their medical insurance, so get both. And I'm running a little short on time, but I want to encourage, again, eye wellness retinal images. Again, a couple of forms that I use. Patient information form. This is provided by the AOA, but a lot of us have electronic medical records. This is a sheet we give out to people, more than 50 ways to prevent diabetes. And again, how I got started, I talked to churches, libraries, and senior housing centers. So I just get out, get my PowerPoint presentation, I talk to the public and partner with local professionals. And this is our logo that Dr. Paula Newsom and I, we have a trademark for Knockout Diabetes. And our team here, we have a registered pharmacist, myself, a dietitian, and diabetes prevention master instructor and a community board. And we had a big diabetes open house symposium where we had a podiatrist and our pharmacist was talking, and we had quite a few people. And in ending, this is our baby. So we strive to knock out diabetes. Now, I don't know if we have time for questions, but I thank you for the opportunity to present the very first Black Eye Care Perspective Symposium. And hopefully this information was helpful for all you guys. So be blessed. This is my contact information if you want to email me. And so be well, see well, be blessed. Thank you, everybody.
Dr. Johnson, great information. I learned quite a bit today. I mean, those statistics were staggering. I had a patient come in not too long ago with one of those wearable things to be able to check their sugar levels. And I heard kind of a similar story, how it really changed their life quite a bit. When they're sleeping, I never even thought about that. So that's something that now I know I could bring to the attention to some of my patients, because we are living in a world where technology is evolving, and we should definitely be talking about these things in the exam rooms. One thing that I know you mentioned was you're talking about gestational diabetes and dilating. Whenever I have someone that comes in and they're pregnant and I never dilate them, like hands are off. So I just wanted to know, is that something that you're actually practicing? If someone comes in and they have the diabetes, you're dilating?
Yes, I will dilate. Yeah, that's not anything that's going to jeopardize anything. So yes, I would dilate them.
Looks like
all right. Well, I got a couple questions. Great job, Ansel. You did an excellent presentation. I like the PowerPoint. It's easy to follow along. Couple questions from the crowd here. When you do your color vision testing on diabetics, are you doing that annually, or are you doing that with retinopathy? And if you bring them back sooner than a year, are you repeating the color vision part? Are you expecting to see a change sooner?
Depends on the result. If it's perfectly normal, then I'll repeat it in a year. If there's a presence or absence of retinopathy, if they don't do well, that test is not the easiest test to do. And just like in the visual field, if I don't feel comfortable with the reliability of the test, I'll repeat it in less than easily. So, but most of the time, say they don't do well, I'll repeat it in 6 months, 4 months, until I'm confident that's consistent. I try not to do it more than 2 months, because the frequency of that test via Medicare, I'm an outlier, because I use that test a lot, and it's very good information, because a lot of ODs don't have it, don't use it. But it's extremely useful in terms of the information you get from it. Not only with people with diabetes or hypertension, other kind of retinal issues too, glaucoma also.
Good. I got a couple more that came in. Do you test A1C or blood sugar in the office with your diabetics? And if so, how?
There's an in-office test called A1C Now. You can Google that, A1C NOW. And you can buy like a 10-pack and use them in your office. Your cost is about $10 each. I charge patients $16 for the test. It's not a big money maker, but I will charge. And then sometimes I'll just write an order and send them to a lab, and they can get it under their insurance. So,
so that's not covered by insurance. That's not a billable test that we can do.
It is a billable test, yeah, but it's almost like chemistry. I'll most of the time I'll just charge them, because it's such a small amount of money. If it's something I really want to know now, I'll just charge them. And if not, I'll just write a script and send them to a lab. So I do both.
All right, I got 2 more for you here, unless somebody gives me some other ones. Has OCTA changed your protocol? So now that you have the angiography with the OCTA, has that changed the way you see diabetics, or now you're getting to see that retinopathy? Has that changed your thought on patients living with diabetes, on how you screen those patients or evaluate those patients, now that you're seeing more information than you've seen previously?
Oh, very much so. I mean, it's just, I do OCTs a lot more frequently. And as we know, you can do OCTs as often as every 30 days. Usually don't do that unless they have some other issue, but I'll do OCTs very frequently, every 3 to 4 months, depending on the results, depending on the dropout, depending on the extent of all the other tests. So I look at everything globally, and then I'll direct, that'll direct my decision making. I haven't looked at the AOA guidelines yet to see if they have a criterion or protocol for that. But again, it's patient-centered, so it depends on the patient and how it looks. Sometimes you don't get a reliable reading on OCTA. So guess what? Just like visual field, you might have to repeat it.
Okay. And then the last one is, does your protocol that you put up there for the test you do change with retinopathy or not? Like a patient has no retinopathy. Can you hear me? Can you hear me now?
Yeah, I can hear you now.
Okay. Does your protocol for a patient workup change with if they have retinopathy or not? Or is your protocol the same and they just wait to get the results back? Like the test you run, does it change if the patient has
change with retinopathy? And I will tell you, 90% of my patients that are living with diabetes, especially when I see OCTA, have some retinopathy. So, but again, it depends on the extent of it. And so I look at it as very individualized. I don't just, there's some patients very mild and I'll say, okay, I'll see you in a year. There's some patients that I might see it initially, then again at 6 months, if it is the same, because my instrument has analytics that can actually measure the nerve fiber thickness. And so if it's the same as 6 months, at that point, then I might say, okay, that's good. We'll just see you yearly going. But also, again, want to know what their numbers are. That's very important also. So if their blood sugar is not stable, I just had someone, about a month ago, I saw this person in August, very, very, in long-standing type 2 diabetes, but problems controlling their blood sugar. Saw them in August, maybe 1 or 2 isolated dot hemorrhages, of course, capillary dropout. For some other reason, I saw them 2 months later. Much more significant, extensive diabetic retinopathy. As a matter of fact, I had to send them to a retinal specialist. And that's the first time I've seen change in that time. And that person actually said that their blood sugar was much better, it was stable. So that kind of lit the fire into me that, sometimes you just might need to see some of these people a little closer. And he had said his blood sugar had been stable, in those 2 months. But it was just early in the year when he was having problems, and he was just kind of reeling it in.
Dr. Ansel, I just wanted to end the segment with one last question, but also just to give you some feedback. I mean, just looking at the comment section, I see thank you, Dr. Ansel. You are awesome. Excellent. Thank you. This was a great presentation. Love the PowerPoint. Excellent information. Thank you for sharing. So you're getting a lot of great feedback in regards to the content that you gave us this evening. So I just want to thank you on behalf of everyone in regards to hanging out with us. And the question that I wanted to ask you, which I think all of us are probably experiencing right now in our practices, is that, for the HEDIS scores to be met, we're seeing a lot of primary care physician and endocrinologists starting to carry retinal cameras. And seeing more patients come in saying, I'm not doing that. I took my photos at my primary care physician or my endocrinologist. And, when we look at your background and everything that you're doing, what is your feedback in regards to that? What are you telling your patients that come in and say that? I mean, I tell them this, that doctor's not looking at the back of your eyes. I'm dilating you. I'm giving you a thorough examination. It's more than just pictures, but like what other information do you have that we can have dialogue with these patients to let them know that they need to see us year in and year out, or how many times they need to due to the diabetes?
Okay. Yeah, that's the easy one. You're right. They're just taking a picture, but they're not looking in your eye. I look in the eye also in addition to the picture, because there's things, little subtle things I can pick up by me physically looking in the eye that the camera missed, and vice versa. They don't know how to put all that together. And again, as I mentioned, it's not only pictures. I have an advantage because I have OCT angiography, but if you don't, there are other things that we do, that the red-free light that I mentioned. So if you have a retinal camera, use your red-free, because they might say this person is fine on their retina photo, but if you see them and you do your red-free and you may see hemorrhages they don't. If you have, what's that wide field screener? But there's a wellness component even with the OCT that will do some OCT angiography with my model, but they're not eye doctors.
Yeah.
They're not eye doctors. And so there's stuff that they can miss. And if they do come in, do one for free just to show them. I'll do this is on me. And let me show you the difference. Or if you see something when you look in their eye, and if I can show you that you have something, you pay me, put that little challenge out there. But maybe that's unprofessional. But I'm just saying, we see, just like at the cardiometabolic conference, I was telling these guys, we see blood vessels all day long.
Yeah.
So no one else has as good a handle on your overall cardiovascular condition than we do.
Yeah. Oh, well, greatly appreciate that. I mean, I'm kind of on the same page as you. I tell these folks, I went to school for X amount of years to look at the eye and study the eye. I know it better than your primary care physician or endocrinologist, and we're going to work together as a team to make this happen.
Mm-hmm.
Definitely wanted to get some input from the expert when it comes to diabetes. Again, we want to thank you for coming out. Everyone, this video will be up to listen to and take notes again. And we look forward to our next interview with Dr. Peters and Dr. Blanc. They're going to be talking to us about nonprofit, the nonprofit world, HEALS organization in particular. I'm very excited about it because Dr. Peters and I were actually almost kind of like family. And she's from Liberia, and that's where my mother's from as well. And our family has known each other for years. So I'm very excited to learn about what their next trip is and how to get into the nonprofit world as well. So make sure you guys tune in. You'll see the dates, the times, the flyers, and all that other jazz. Dr. Johnson, thank you again. Dr. Ramsey, is there anything that I'm missing, sir?
No, excellent presentation. Great first start. I love the feedback, and thanks for all the engagement today. Thank you for taking the time, Dr. Johnson. Much appreciated, and we'll see everybody on the next one.
NOA Convention, July 9th, 2020.
Yes.
You'll see more.
We will be there.
You'll see more. Thank you.
All right, thanks.
Thank you again.